Okay, well, my clock says it's 2:15, so let's go ahead and get started. Hello and welcome everyone. We're happy to have you. Thanks for joining this session, implementing opioid and substance use screenings for perinatal patients. Sorry. So just a few quick housekeeping things. I'm sure you've already heard this a few times today, but one more time. This session is recorded and will be available on the conference platform 1 hour after the session ends. Please keep yourself muted unless the presenter asks otherwise. Make sure to join sessions live today because we'll be doing a prize drawing from attendance within each session. The conference is also offering free continuing education credits, and you can, if you need more information, you can check that out on the continuing education page. And the presenters would like, if we could hold off on questions till the end, and or if you have something, you can go ahead and put it in the chat. But otherwise, they'll be answering questions the last few minutes. And with that, I will turn it over to Patricia and Shane.
Thank you so much, Nancy. And thank you everyone for being here today at the end of what I'm sure has been a really long and hopefully interesting and educational day. Myself and Shane are very happy to be here today speaking on behalf of the Kansas Communities grant on implementing opioid and substance use screenings for perinatal patients. So just a quick introduction of myself. My name is Patricia Carrillo. I work at KU's Center for Public Partnerships and Research as a project coordinator and have served as the program manager for the Kansas Connecting Communities grant for the last several years. I'm joined with us today by Shane Hudson, who is president and CEO of CKF Addiction Treatment, where he has served in various capacities over the last 11 years. Shane is a licensed clinician who has also completed a master's of healthcare transformation at the University of Texas, Austin in 2020. He's a member of numerous local and state committees in order to provide advocacy for Kansans suffering from addiction, as well as the field of addiction treatment as a whole. Shane is recognized as a leader in promoting screening in medical settings, medication-assisted treatment, and the use of technology to improve access to services. And in 2021, Shane was appointed by Governor Laura Kelly to serve as the governor's Behavioral Health Services Planning Council. So really appreciative to Shane for being here today to speak with us and being involved in the KCC project. Just a few objectives for today's presentation. We hope that you'll walk away from today better understanding the purpose and value of organization-wide screening policies for substance use for clients or patients during the perinatal period, as well as be more knowledgeable around perinatal substance use screening and follow-up best practices, including response protocols for positive screens and crisis interventions. And lastly, we hope to be able to help you guys in supporting the identification of resources to support providers like yourself with screening, referring, and treating perinatal behavioral health disorders. So we'll have a few resources to share that will help you in those objectives. I'd like to give a brief introduction and overview of the Kansas Connecting Communities grant, which is supporting this presentation today, before handing it over to Shane to dig into kind of the meat of today's presentation, focusing on perinatal substance use and substance use intervention best practices. But Kansas Connecting Communities is a 5-year federally funded grant administered by our Kansas Department of Health and Environment and involves a variety of state and local partnerships, all with the aim of improving maternal and child health outcomes through building provider capacity to support the early identification and interventions in perinatal mental health, as well as substance use disorders. So Kansas Connecting Communities, or KCC, achieves this through a variety of mechanisms, which we'll touch on here today. But just briefly, that includes free access to training as well as technical assistance, a psychiatric consultation line, which Shane and myself will share a little bit more about, as well as a number of other resources, including a perinatal mental health and substance use toolkit aimed at supporting providers who are implementing universal perinatal behavioral health screening and interventions. So with that, I would love to hand it over to Shane to get us going for today. Thank you so much.
Thanks, Patricia. I appreciate the intro, and thanks everyone for attending today. Hopefully you get some valuable information from this session. Just to start things off and talk a little bit about how I got involved with this, CKF got involved with this. We're starting our 4th year with this project and the grant that's flowing through this. And it was probably 4 years ago, because we've been doing it 3 years, that I got an email from KDH&E and started talking about what we could do to help really positively impact the health outcomes of perinatal women. So focusing on pregnant and postpartum population and what can we do there to really help these individuals when it comes to screening for substance use, engaging in the right service, et cetera. So that's where CKF came in line, that we'd been doing some work around the opioid grant and getting some services stretched out to Western Kansas via telehealth and telehealth support groups. And the focus was really about telehealth and how do we create screening mechanisms and telehealth assessments and telehealth treatment programs for women who might not otherwise have that available, for clinics who maybe haven't been asking these questions and could then have a resource available to them. As we've gone along, we've really looked at some other components, and especially when you look at clinics that are specifically working with pregnant women, how does that compare to what we're doing in primary care clinics in general? What are the implications of the services we have available? So I'll tell you just a story that came up as we were working with OB clinic. I was like, man, I used to work in child welfare, and I remember going to the hospital in Topeka to pick up a newborn. And just thinking about this process, you walk into the hospital and this child's being taken away from their family. The child was just born, and you walk in, it's very awkward that you're taking this child away, and you're going to start planning the visits with them and working through this process to hopefully get the right resources to the parents and help this environment so the child can be returned to the parents so you don't have to go some other routes. But that's a really odd place to enter the picture. And it just made me think, like, there's got to be a system change. There's got to be a way to have conversations about this earlier on. Are we even asking questions about substance use in general, let alone women who are pregnant, and kind of working with them alongside them to make a plan? And maybe we were, but I think there's better things we can do to really avoid those types of outcomes and start conversations sooner. So that's really a driving force for me, is to impact that as we talk to OB clinics and figure out how to do a better job in that area. Slide. So when you look at the data and you think about substance use, just generally speaking, and any of you have heard me present, I say this data over and over, but it's about 1 in 10 Americans could be diagnosed, and that's ages 12 and older. That's a general look at it. If we say 10% of those across the country could be diagnosed with a substance use disorder, that's a lot of people. When you drill down into that and you think about, well, do we know that those individuals even exist? Are we talking to them about substance use in helpful ways? Are we framing substance use as a chronic illness? Do they know resources exist? Do they know that this is a part of healthcare, and with healthcare, you get to the right healthcare resource so you can try to get better and heal? And the answer is we don't do it nearly enough. So across the country, it's not being done nearly enough. We've made some headway in Kansas, which is exciting, and I'll share a little bit about that. When you look at the data, if we were screening in primary care, so once again, kind of looking out at the general population coming through primary care, a quarter, 25% of the patients coming through primary care currently would screen positive for moderate to high risk substance use. Not addiction per se, not diagnosable per se. Some of those individuals would be diagnosable, but just seeing that substance use is something that's really affecting them or could really affect them in a negative way. If we're asking the question, we would understand that about the patients already showing up in primary care, and we're missing that component. In acute care, if we were looking at all the pieces and establishing a diagnosis and making sure the person's getting the resources they need and documenting the substance use and the diagnosis clearly in the electronic record, which is largely lacking across the country, we would see that about 17% would discharge with a diagnosable substance use disorder. So there are a lot of people, general population, there are a lot of people out there who are struggling with this chronic condition that we don't speak about nearly enough, that we don't identify in care settings nearly enough, that we don't give the right resources to nearly enough. So then when you focus specifically on this population, 1 in 5 women reporting smoking cigarettes in the past 2 years. Alcohol use during the 3 months leading up, so before pregnancy, was 67.6%. This is prevalent. This is substance use that is affecting not just the woman, but the child that's developing. Nearly 1 in 13 women reported having prescription pain relievers during pregnancy. And are we talking about it? Do we even think about these things that are affecting the brain and the body's functioning and this developing child? Are we doing anything? Are we helping these women enough? The 5% of pregnant women using 1 or more addictive substances, to go on with the data, and then the CDC self-reported data showing about 7% of women reported using prescription opioid pain relievers during pregnancy. And there is treatment available for this. And when you talk about medications available, we have a clinic that prescribes Suboxone and Subutex. There are medications that women can take even when they're pregnant that won't harm the child and will help the woman as she's trying to find recovery from substance use and manage that condition. So there are resources available, but with this data just sitting there, do we do enough about it? And I'll tell you that it's an uphill battle to really get integrated services or co-located services or even tightly coordinated services within healthcare settings, and to even open up these conversations and talk about this enough so that it can benefit patients. The question is, through care settings, do the individuals working at care settings, if you're working at care setting, do you know your patients well enough? Do you understand what's happening below their neck as well as above their neck? So brain function and behavior and substance use and mental health and all these things that are occurring, what's going on with your patient? And do you really understand all those pieces? Because if you don't understand all those pieces, you're not really going to be able to treat any one thing as effectively as you would if you understood the full dynamic individual, because we're all individuals and there's layers involved, and you're missing a huge component of their health if you're not talking about this, let alone the child that's developing in pregnant women. Slide. So those associated risks and impacts, as you speak specific to women who are pregnant and give birth to a child who has substance use occurring as the woman's pregnant and the child is born, what happens? Well, it really can affect the child in ways such as when you look at fetal alcohol syndrome and attachment and other developmental delays. Of course, there can be social and legal outcomes. I touched on that when a woman is pregnant with a child, and speaking specifically to Kansas, there's not going to be a legal outcome while the woman's pregnant. Now, if the woman has the child, and then, me showing up as a child welfare worker in the past and the court getting involved, then there is a focus on the legal side of it. So really the time to engage with women who are using substances is before they have the child. You can really talk about what it looks like if the woman doesn't get help potentially, and what that could do to her health and her child, and what those legal effects could be, what resources you could give her and how you could support her before the child's born, and how that could end up for the individual and what the benefits of that are. Having these open conversations versus hiding something that's only going to get worse for the individual and their health outcomes and their family and their stability and the legal components. So talking about it early on is a very important component, or you're going to be facing these risks. And even without being pregnant, an individual struggling with addiction, that's a very tough thing, but because it requires change, and change is very difficult. It requires motivation to change. It requires sticking with it over and over and over. It's a chronic condition, so it's not going to just disappear and be something that you don't have to think about anymore once you heal. You have to manage it lifelong. You have to understand chronic disease management. So it is a difficult road, but it starts with understanding that it's okay to talk about, that it's a treatable condition, that healthcare providers are on your side. And yes, there are some components, as I talk later, about mandated reporting. However, how do we have healthy conversations, even when it comes to mandated reporting, with our patients, and understand them better and build rapport and show that we're really looking out for their best interests and the child's best interests, and we can talk about these things and we don't have to hide what the different avenues and the outcomes might be, that we can talk about it out loud. When you look at addiction as a chronic condition and patients getting into the right healthcare setting, so into addiction healthcare or treatment settings, it's only about 1 in 10 of those patients. So if 1 in 10 Americans could be diagnosed and only 1 in 10 of those 1 in 10 are getting into the right healthcare setting, what are we doing wrong? I'd say we're not nearly doing enough for these patients. You look at other chronic conditions, diabetes, high blood pressure, 7 in 10 patients. So 70% of those individuals are getting the right healthcare, and 10% of the individuals struggling with addiction are not getting the right healthcare. And that's a big problem if we're not talking about it. We're not asking the question, identifying the patients, figuring out what the resources are and how to communicate with those resources and make referrals, identifying maybe that there's not enough resources or enough healthcare settings that treat these patients. That's good information to have, but we don't get there if we don't start asking the question. We just kind of act like it's not happening. There are people around us struggling with substance use, and if you act like it's not happening and you're not interested in adding questions and asking the patients how they're doing, you just act like it's not real, it doesn't matter. And it's really affecting the health of individuals across the United States. The 20% of deaths in the United States addiction is responsible for. There's preventable health problems, and there's resources available for these patients. So we have to do a better job as far as that's concerned. Slide. So some things as we dig in and look at what we've seen across Kansas as we've worked with healthcare settings, because we have put work into this process to align with healthcare settings, not just through KCC, but otherwise. How do we talk to clinical settings, primary care specifically, OBGYNs, about the need for this service? How do we really build in the right things? So part of it is presenting information, like really talking about addiction in ways that's meaningful. How do we normalize the conversation? Talk about addiction. It's okay to talk about. It is a chronic condition. How do we talk about addiction? How we speak about it matters. So a big part of that is educating. And we do a lot of presentations for individual clinics via conferences like this to talk about what addiction is not. But we need every layer of an organization to really engage. So you're talking administrative level, the physicians, the nursing staff, the frontline workers, the clerical staff. Everyone needs to speak the right language and understand addiction and substance use, and that it's okay to screen for this and talk about it and understand where our patients are coming from. I will tell you something that comes up and has come up probably more so in the past than recently, but it's like, oh, well, we don't want to be an addiction treatment center. If we start asking people if they use substances, we might find out that some of them are. Oh, and what if people who don't use, our services currently start running to us because we say, hey, we treat addiction now. And then we've got all these criminals here, right? Which is a stereotype. And we know that with that, about 72%, at least through our setting and national data I've seen, of patients coming through are criminal justice referrals, and very few, about 6%, are referred by healthcare. And that's national data as well. But we're not doing a good job referring the people who need the service. So when you say 10% of the people are showing up, and the majority of those people are referred by criminal justice, and you're not even looking at the other 90%, and that stigma exists. So we're not even going to ask people the question because, oh no, what if we become ... That doesn't make any sense. So understand the patients who are coming through your care setting and understand them as well as you possibly can. Because if you're not asking questions and understanding your patients, you're not going to be able to do as an effective job as you would like to. The workflow components, we have gone into clinics and worked with them on building screenings. How do we set up a clean workflow to screen, to talk to the patient again if they're coming through multiple times, to refer the patient, and how do you make that a clean process so it doesn't get lost in between, again, the gaps here? What kind of guidelines do we have in place that we can set up for staff? And across settings, it can be pretty consistent. Staff can speak common language and know what the guidelines there across the screening components. Reimbursement is something that comes up, and there are some settings who, well, we don't want to, it doesn't matter if we get reimbursed for the screening, this is just a good service, and if we understand our patients, it's going to be a benefit, et cetera, et cetera. And some settings do want to have reimbursement for any kind of service you build in, so that could be a selling point. There is a reimbursable screen, which I'll speak specifically about, which is ESPERT. There are some other screenings, such as ASSIST, which Patricia can speak to a little bit. When you're getting into the resource and referral, it can be a really confusing thing, and that's a huge gap. How do you jump this gap from primary care and all the knowledge and the great skill that exists there and the service provided to the patient, and then say, okay, here's this other service over here that's really kind of foreign? Because we're set up in these silos that you kind of have, primary care and acute care and mental health centers and substance use disorder treatment providers and all these different silos that exist. How do you really do an effective job building your referral mechanisms and having the right resources on board? So you can do that via partnerships, which we've done. You can do that just by understanding the resources better and really speaking to those places. I would say if you haven't spoken to every place you might actually send a patient to, before you send the patient, before you make the referral, you're missing out on some things that could really strengthen your process. You're missing out on understanding what are the things on that side of the fence that they face. Because I'll tell you that within addiction healthcare, there are very specific things that cause people to scratch their heads or think that, we're difficult to work with maybe. I'll tell you two of the big ones that come up. One would be that oftentimes a treatment provider will say, well, an assessment needs to be completed before we can do fill in the blank, residential care, outpatient, et cetera. Like, have they been assessed? Well, we can't do anything yet. They need to be assessed first. And there may be some things you can do together to work on that, tightening up the referral form and the information included on it, working closely with some treatment providers around like, how do we make this a better process when someone really needs your care, but then we say they have to wait X number of days to get assessed, and then we can find out if they need the right care. There might be some things there. There might be some agencies that will say, well, that's the first thing you have to do, so sorry. And then the other thing I would say that's come up often is really around our releases of information. We have this thing called CFR 42 Part 2. And for instance, if any other facility gets a release signed, and it's not that specific type of release that includes those types of components in it that are required, and they say, hey, I referred this person to you, I'm just calling to see if they ever showed up, and the person didn't show up, I can't share any information about that person. So that's very frustrating, but we don't have that special kind of release signed. And there are some workarounds as you talk about really coordinating care that you can do with that, so you can really communicate better and not just have someone super frustrated with the addiction healthcare facility that we're not sharing information. Similar things have come up in the past as far as like police showing up and saying, hey, I need to talk to this person, and saying, oh, well, we can't confirm or deny. Oh, you have this thing we need to deliver. If they're here, we'll let them have this information, but we can't tell you anything. So I've just seen that historically, and I've been at CKF for 11 years, and I've seen some of the frustration that happens within that kind of network of referring providers or even within a community. And then another thing, lack of access to psychiatric treatment. It's very hard to find timely psychiatric care, and it's an expensive service. So we've tried to build services around psychiatry a few times. We've had that service in-house. We had it for quite a few years, and we don't have it currently. And it just really gets into, there are plenty of great things you can do for patients, but how do you afford to do it, sustain it, scale it? What's your intention when you're building something? And can you make it last? But with this KCC model, there is a great component in there that includes psychiatry. Slide. So as we get into best practice and recommendations, I've touched on some of these things, but how can we do better? So accepting addiction as a disease. That's the number one thing. If you're talking about addiction and you're not speaking the right language and you're not speaking to it as a chronic disease, you're really missing out on valuable components. Because, and kind of focus on it this way, if you're supporting a patient who has diabetes, who has high blood pressure, who has asthma, if that patient's managing a chronic condition, how do you work with that patient? How do you talk to that patient? How do you engage that patient? Are you like, man, I can't wait for this person to get out of here so I never have to see him again, and hopefully they stop using substances because that was uncomfortable? That's a very specific, I don't know what to do with this, versus how we treat patients with other chronic conditions. It doesn't add up oftentimes. And I have heard physicians talk about a patient with diabetes saying, this person's frustrating to work with. And that's just being honest as a human, right? They're frustrating to work with. This person doesn't come every time they're scheduled, or they come and their symptoms are really bad, or they haven't done the things we've talked about doing, and that's frustrating. But with addiction, there's even extra things on there that add to the stigma of like, well, then maybe they need to go somewhere else for care, because why am I helping treat them? That's not really what I do. And there is a place for healthcare, primary care physicians, nursing staff within traditional healthcare settings to support these patients and engage with them long-term and have conversations. So the language we use and how we talk about addiction matters. If we're not asking the question, we don't understand the people who are currently coming through our settings. And don't you want to understand the patient you're working with? Don't you want to help them as best you can? I went into healthcare to be a therapist. So I thought that'd be really cool to help people with mental health diagnoses and symptoms and add that support. But we want to help people, right? We're in this profession to help people and see them get better and succeed in life and stabilize. So why wouldn't we be asking these questions if we really want to see a patient do well, to understand that patient in a fuller way? Understanding resources and coordinating care. So if you don't know what resources to send the patient to, you're likely not going to use the right resources or understand how to access the resources correctly. And tighten that up by talking to those providers and really figuring out a plan to coordinate care. You can develop workflows together. You can have something for providers to reference. What do I do when this patient shows up and they have this need? Because I've seen providers, medical providers kind of work in the dark and feel their way out and try to get the patient the right care. And I've seen that end poorly sometimes, and sometimes it gets figured out as they're going along. But why don't we talk about this before our sides of the fence are trying to communicate and understand each other and do the right thing for the patient? Medication is okay for patients with substance use disorder. And there's a long history behind this, but essentially in the 1970s, when individuals are coming back from Vietnam and drug use and the drug culture was spiking up more so in the United States, and we had this new silo pop up that was going to treat addiction versus mainstream healthcare treating addiction, because mainstream healthcare is like, we don't really know what to do with this. And there was some acute services available, but a lot of it was a part of this new silo that popped up. And a part of that was, it was via, the pharmaceutical companies were not willing to create medications for patients with addiction because it wasn't going to make them money. They didn't believe there was a high enough perceived need for that, and that it wasn't going to make them enough money. So years later, the first medication came out and it was antabuse, which there's probably different opinions and feelings about that. But I will say that if you give someone a medication that punishes them when they do this behavior that you're trying to extinguish, that's kind of an odd way to approach someone in their health. It's like, well, here's this medication, and if you do that thing that's bad, you will be punished, and it'll have that effect on you. And I've heard some people who say like, well, this is a medication that helped me. Fair enough. It would not be the medication I would choose at the top of my list for patients. But with all that being said, the stigma around patients with addiction, well, it's not a chronic disease. They decided to do this, and they can't even have medication because they're addicted to substances. So don't give them any medication. That'd be bad. And that's not true. And our patients can have medications that can benefit them, and medication assisted treatment. And even if you want to speak about a very basic one, nicotine replacement therapy, that is MAT. You're delivering nicotine in a different way that's not wrapped in tobacco and harmful components. Similarly, delivering other substances to the brain and helping the brain function in a way that's quote unquote kind of the average non-addicted brain functioning. That is okay to do, and it's not harming the patient. They're not meeting criteria for addiction as you're working with them, and you are engaging them in counseling services concurrently. Treat the biological, psychological, social, spiritual components. We're all layered individuals. No two people are the same, and we need to understand that as we're working with individuals, that there are all these components in their lives they need to figure out, which are interwoven with the substance use and the addiction. If you really break it down and understand those pieces, that's what people need to work on in total. It's not just stopping the substance. And I say that, I know it's very hard to stop the substance, but it's not that one thing. It's many different things, and you need to understand the individuals you're working with. And then follow-up care, that's a huge component that's largely missing in addiction healthcare. And there's reasons for it. And it's not because addiction healthcare providers just want to say, all right, see you later. I guess we did our work, and we don't want to work with you anymore. It really gets tied into how we get reimbursed, authorization being active. And maybe we're not the ones who need to do follow-up care long-term, and that's okay. We need to create warm handoffs with primary care, but we need to create warm handoffs to agencies who are speaking about addiction in the right ways and are comfortable talking about substance use long-term, so that person keeps talking about how they're doing, just like you would with any other chronic condition. Slide. So our goals, what are we doing when we're screening? We're understanding the patients better. Yes. Behavioral health vital signs. Do we understand substance use, anxiety, depression, suicidality? What are these things that we're not going to understand as we put them on the scale or take their blood pressure or ask the other screening questions we're asking about physical health and symptoms? Are we asking the right questions about behavioral health? We're not trying to have providers diagnose patients. It's identifying people who, once again, have that moderate to high risk use occurring, and really building rapport. And it doesn't matter what screening instrument you're using. And down here talks about the building rapport, supporting the patient long-term. It doesn't matter what instrument you're using. It is about building rapport, being a support for that individual, normalizing the conversation, letting them know it's okay to talk about what's going on with your health when you walk into a healthcare setting. That's a perfect place to talk about your health and talk about what's going on. So not diagnosing, but understanding your patients better and getting them connected to the right care when they're ready. It's not about forcing someone into the right care. Now, there are some examples of that, court-ordered treatment, getting a judge to sign off on it, et cetera. I'll tell you, largely, I don't see that happen at CCAF. We have a 30-bed residential and detox facility and outpatient care. So I don't see that often. That is something that can occur, but those are for pretty extreme and acute circumstances. By and large, people are deciding when they step into addiction healthcare and when they're ready for it. And if you push them into it, there's some data that says they can benefit from that still, but it's much better to have a solid relationship and see that person come back and see you again and again and have an open conversation about substance use than to scare them away because you're pushing on something they're not ready for. So remember motivational interviewing and engaging with patients in a positive way. Next slide. So SBIRT is what we use and train agencies on. It doesn't mean every agency we work with has decided to use SBIRT, and that's okay. But once again, what's right for the setting? Are they wanting to bill? Are they wanting to ask some other questions that aren't just about substance use? So if they're asking other mental health symptom questions, maybe there's another screening they'll use. But as we build it in, it is that we're setting up screening annually for every patient. So aligning it with other processes is very important, or it will likely get left off of the list of things. So how do you align it with things that are already occurring? Make sure that it occurs consistently over time. Ask patients annually what's going on with substance use. And then if there's indication that substance use is problematic, that moderate to high risk use, following up and having a deeper conversation to understand what's occurring there. Offering education, resources, understanding where the patient is at and if they even want those things at that moment in time, but continuing to have that conversation long-term. Remember, establishing rapport, listening to the patient, using motivational interviewing. If you're familiar or not, look that up. It's a very good thing. And there's some tools you can utilize and remember when you're working with patients, but being open to where they're at and what their process is important. And referring that patient to treatment when they're ready. And if they're not ready, keep the conversation going, keep them engaged through your clinic. Patricia, is there anything you want to say about assist on this slide?
Yeah, thanks so much for that opening, Shane. I just wanted to mention this specific infographic and much of the information that's following can be found in KDHE's perinatal substance use toolkits. So that model of intervention is really based upon the SBIRT process. So screening, brief intervention, and referral to treatment. Within that, KDHE has made a couple recommendations on screening tools specifically for our perinatal populations. And one of them that's highlighted in that toolkit is the ASSIST, which was created by the WHO. So that's the Alcohol, Smoking, and Substance Use Intervention and Screening Test. I think I got all those letters. But Shane, and I think you would speak to this as well. One of the benefits of that, other than it being validated, is the inclusion of alcohol, smoking, and substance use all in one tool. So really looking at those somewhat equally when talking to perinatal clients, I think helps reduce the stigma associated with one substance or another, and really just reinforces what Shane has been saying, the fact that these are chronic health conditions, which may require some different treatment options, but ultimately should be looked at in a holistic way. So nothing else specific to add about the ASSIST, Shane, other than resources around it, as well as SBIRT and other perinatal substance use kind of language and templates are available in the toolkits, which we'll share a little bit more about here in a second.
And something important, as you mentioned, tobacco use. That's a diagnosis that I wish was included more broadly in billing components, that we could treat patients for their tobacco use and bill for it in similar ways as we do for other diagnoses. There are some special codes and you can do some services around it. When you talk about diagnoses and those health effects that are leading to the most deaths, tobacco use is the leading cause of death for patients coming through mental health centers and substance use disorder treatment agencies. The related effects of tobacco use are killing the most individuals. So it really is a very important and a big deal. We're tobacco free at all of our treatment agencies and provide nicotine replacement therapy to our patients in residential and outpatient care. But don't underestimate those long-term effects that tobacco use and smoking are having on individuals you're working with, and make sure you're talking about that as well. Next slide. So one of the things that came up as we were talking about this with, I can't remember who it was on that call, Patricia, but they were asking about mandated reporting. So I wanted to mention that somewhere in here because there are better ways and not so good ways to go about aligning with the individual you're working with. If you are delivering a healthcare service and you are watching out for the health of your patient and the child that's going to be born, how do we talk about mandated reporting and how do we really support the individual to say, we're doing this because we want to help, not because we want to see you get in trouble. So it's not a punitive thing, and it can have those outcomes as far as those negative consequences. But should you talk to someone about, here's mandated reporting, and here's what I would have to share if you brought it up, if you're harming a child, elderly, et cetera, like I'm going to have to talk about this. Now, let's say you deliver that to the person. They're like, yeah, I understand. And then you hear something while they're talking. And when they leave your office, you're like, oh, got to get online and submit this, or I've got a call. That's not good. And that's damaging the relationship and the rapport you have with that individual that you're serving. How do you step back and talk to them about, this is something that was just brought up. Here's why this stuck out to me. And really that mandated reporting conversation. Here's what I need to do with that information now that it was said. And once again, you're telling them ahead of time about mandated reporting, but really having the conversation that, let's talk about this. Here's why I'm doing this. Here's what these outcomes could be that could benefit you. Let's make this call together. Let's get this report submitted and understand what resources could be available to you so that we can align the right resources along with you. We can keep talking about it. Why should you have this thing behind this curtain and hide it from them and surprise them with it? That's stressful and that's harmful and damaging for the individual. So I just think there's better ways of mandated reporting to, yes, make the person aware, but to align with them as you're going through this process and really let them know they can trust you. And maybe you're not always saying things they want to say, but you're being honest and you're being open and you're trying to figure out, in a tough situation, how do you help this individual, even if they can't see that this is a helpful thing yet, or that they want to be a part of this process, and show them that it can be a helpful resource. So keep that in mind as you're talking to patients and when mandated reporting is involved, versus surprising them with it, not really letting them know you're even doing it. And then they're like, oh, I guess my provider did it. I didn't even know they were going to make this call. Training and staff education, implementation planning. We've been working with agencies around things such as that communication piece, establishing memorandums of understanding, so you know what to expect from each other as agencies is always a very good thing if you're working with partner agencies and coordinating care. But business associates agreement is something that we've also used with all the agencies we work with. So when I talk about a healthcare provider getting a release signed, sending the patient to us, then asking if the patient ever engaged, and I say, sorry, I can't confirm or deny, and they look at me crazy like, we've talked about this patient, I just referred them to you, with a business associates agreement in place and notifying patients that we have this relationship and we have one signed, we can talk about the patient. So that's something that qualifies under that 42 CFR Part 2. It doesn't mean I won't then get a release signed for CKF or whatever agency we're talking about, but it is a way that we can have a cleaner route of communication and really understand what's going on with the patient through that process. So I would recommend having a business associates agreement so you can really talk about if the patient engaged and what we can do next to engage with the patient. And of course, notifying patients that you have this relationship as you make the referral, that we communicate about patients and have this agreement in place. So with each agency we work with, it's a little bit different as far as where are they coming from with their screening process? Have they ever done screening before? Are they motivated to change to maybe a better screening or tightening up the screening they have in place, making it consistent, training staff as a team and really engaging with those providers who are delivering the care and making the referrals? And how do we make sure this is a good process? So checking back in on it to say, hey, are you getting what you need from us? Did this go well? Do you get the information you need timely? Is the patient getting the right care? Have you heard anything otherwise from the patients that this wasn't the right service for them or it didn't work how they thought it would? Make sure that you're looking at those policies and procedures around quality and through that patient lens, but also each partner site and the sides of the fence that we're trying to navigate and bridge that gap. How do we make it a clean process and achieve outcomes? Next slide. So the list of resources available, and I'll add one to this, and then Patricia, I'll let you speak a little bit to some of these if you want to mention the toolkits and just the ease of use there. But one of the things I do for clinics, and as we've worked with KCC for going on 4 years now, is if a provider wants to meet with me, if I need to do a Zoom call, travel to you, do a group presentation or have a discussion about screening mechanisms, about educating staff, building in these components that are going to provide a better service to patients, we've done those things. I mean, we have 13 partner clinics across the state that we do telehealth assessments and services for their patients, that we've built in screening process to get those referrals. You don't have to work with us. Even if I come and help you and do it through this grant, you don't have to work with us. And of course, go talk to other providers and ask them how you can build the processes and really create clean workflows for referrals. Patricia, was there anything else you wanted to mention for this slide as far as specific to your toolkits and links?
Yeah, Shane, do you want to speak to the consultation line, or do you want me to do that all in one right now?
Yeah, I think the next slide had maybe a further breakdown, so I was going to speak to it on the next slide.
Great, I'll just mention it briefly, but certainly we've been talking about a lot of opportunities today. Shane has mentioned, I think, a lot of practical steps and considerations when thinking about identifying substance use with perinatal populations, but certainly this applies to all populations. So just letting folks know that there have been a variety of resources compiled to help you guys do this work. So certainly there's no need to invent the wheel when it comes to developing algorithms or local policy templates, as well as some patient resources and provider-facing resources around use of language, as well as a host of other resources. So just wanted to mention those toolkits do exist and are quite robust with resources. So would highly encourage folks who are engaging in this work, be it through universal screening implementation or be it just trying to, as Shane has spoken about, speak the language of addiction and better help folks with their treatment planning and health outcomes. These toolkits are really valuable resources for folks.
Thanks, Patricia. Next slide. So there's other components at play here. And of course, when it comes to other screening and talking about mental health symptoms and screening for those, there is a consultation line available, as Patricia alluded to. So if a patient's coming through and the staff have questions, here's what's going on with the individual. If there's depression, if there's anxiety, substance use occurring, I don't really know what to do next, or I remember talking about this, but like, I'm struggling with this next step. What do I do? And you can use this consultation line to reach out. We have staff available via CKF. So our director of telehealth services and her staff are those who answer the consultation line. So that first step to call in and say, hey, what about this? What do I do? What are the resources? How can I best help this patient? We have people available to you to answer those questions. It is Monday through Friday, 8 to 5, and a response within 24 hours. Of course, if it's on a Friday, it'll be by Monday. There's not a 24/7 component or a weekend component, but it's as timely as we can be with the staff we have and getting a really quality service as far as feedback from professionals in the behavioral health field about what to do next for this patient. Now, if it's about medications, if it's more in line with psychiatry and needing to talk about the medications prescribed or that could be prescribed, what do you do then? Because our staff are not psychiatrists. We do have psychiatry staff that we can connect you to speak to them and talk about what's best for the patient, what might be a good resource for the patient, what's the next best option, et cetera. And on top of that, if a patient needs to engage with a psychiatrist, a patient can get engaged and do a psychiatric evaluation and a medication review with a psychiatrist via KCC. And it all starts by engaging through this consultation line to get the patient that resource. So psychiatry, as you all know, it's expensive. It's hard to find timely. There's typically waiting lists. What if you have a patient come through who just really needs to engage with a psychiatrist who's pregnant and postpartum? You can engage through this line and utilize that resource. So that's a really amazing and cool thing. I think we've seen increase in use of the line. I still don't think the line's used nearly enough. I think there's a lot of potential there. And if individuals engage with this line, it's going to be a really helpful avenue. And especially when it comes to psychiatry appointments, because I know those are hard to find. So maybe you know all the resources and know what to do next, and you don't often have questions. But if you do, you can just call and ask questions. But surely you know patients who need to engage with psychiatry more quickly than maybe the waiting list that they're sitting on currently. So Patricia, any more feedback on the consultation line?
I just wanted to highlight, which this slide doesn't, since I haven't updated it yet, but we had a very exciting staffing change this last year in the consultation line. So recognizing for many providers, be they physicians or psychiatrists, often individuals who are pregnant or breastfeeding can be a perceived challenge to support when it comes to medication, just because of all the nuances, as well as research that goes into assessing risk associated with medications. So just wanted to highlight that as of this year, the consultation line is staffed by our new perinatal psychiatrist, Dr. Erin Biter, who works out of KU Med Center and is also a partner in this KCC work. So certainly encourage folks to reach out to the line, get connected with our friends at CKF, like Shane said, just to have those conversations, ask those questions. And then also, if you are a prescriber or no prescribers, definitely excited that Kansas has this new wealth of perinatal psychiatry knowledge in Dr. Biter, and she's supporting the line. So thanks so much, Shane.
And Patricia, just to highlight, do people need to contact you and sign up? Can they just use it? I think this is a good thing to say out loud.
Yeah, great question. And also, I think another big thing, if it doesn't say on here, this is a free resource for Kansas providers. So no, you don't need to be connected or enrolled in the KCC program whatsoever to access the consultation line. Certainly, if you are interested in accessing training or technical assistance, we can help facilitate that through the line. But the line is truly available to any providers, be they physician, public health, home visitors who are supporting perinatal clients.
I'll use it. Awesome. Free, ready to go right now. It's a good resource. All right, next slide. All right, well, Patricia, this is your slide, I guess, if you want to mention anything here. Of course, anyone who wants to contact me, I think my email address is logged with the agenda for today. Surely you can find it, but of course, if you ask anyone for my email address via DECA or the event, I'm happy to answer any questions via email, and we'll do questions here in just a minute, unless Patricia has anything else to share before we do that.
No, Shane, thank you so much for speaking on this today and for being a partner in this KCC work. We really value your expertise and are excited to share these resources with folks and certainly answer any questions that may have popped up from today.
I do have, did I just hear your name of Danelle? Danelle, I'm calling you out if you're still listening. We have our APRN here through our MAT clinic. So if there are questions about perinatal women and MAT, we do have our APRN. There she is. Hey, Danelle. Available. She can answer questions about that much better than I can. I can only act like I know what I'm talking about for so long when it comes to MAT, and Danelle does it every day. So if there are any questions specific to that and medications available to women who are struggling with substance use, Danelle's a great resource. And Danelle, if anything we said stuck out to you and you want to comment, that's okay. But I just figured if someone had questions, you'd be a better person to answer about that than I would.
Yeah, thank you, Shane and Patricia. I think that we need more people talking about MAT for pregnancy. I think a lot of people think that you can't be on it while you're pregnant, which is not true for OUD especially. Alcohol use disorder is a little bit more tricky, but OUD for sure. We do Subutex for pregnancy and moms do really well with it. So just spreading the word, and getting people to engage in treatment is something we need to all focus on.
Awesome. Thanks, Danelle. I appreciate that.
Do we have any other questions before we sign off? We've got a few more minutes here.
Anyone has a talent they'd like to share, just turn your camera on.
Shane and Patricia, would you be okay to hang on till 3:15? So if any questions pop up?
I'm happy to, and Shane, if you need to pop out, happy to pass along any questions also.
All right, sounds good. Thank you.
Well, thanks to both of you. That was a really great session, chock full of good information. We sure appreciate you.
Thank you all. Happy Wednesday.
Hopefully we'll be able to meet in person next year. I'm cautiously hopeful we can.
Yeah, I'm cautiously optimistic. I got an email today about a January in-person conference, the KAPN conference, I think. So fingers crossed. I haven't really been out of the house since March 20, was it 2019, 2020? I don't know when we started.
Where is it located?
I think they're hosting it in Lenexa.
Okay.
Yeah. Although I definitely think we should do a collective petition to maybe not have conference season at the same time as flu season. Just, you know, moving forward as a society.
Yes, makes a lot of sense. Well, it looks like it's 3:15, so I'm gonna go ahead and end the meeting.
Great. Thank you so much, Nancy. Have a
Thank
good
you.